Good morning, everyone. So we'll get it started. Thank you for joining us in today's eShadowing session. Today we have Dr. Kaina Hasnie, who is an otolaryngologist, and will be sharing her journey towards medicine and towards her field of otolaryngology. As a reminder, don't forget to take. We don't have assessment today, so once the assessment link is posted in the chat, just feel free to click on it and just mark that you have attended for today's session, so that way like we can receive your hour for the session. So without any further ado, I would like to introduce Dr. Kaina for her presentation. Dr. Whenever you're ready.
Okay. Hey, everyone. So I'm Kaina Hasnie. I'm a third-year otolaryngology resident at the University of Oklahoma. So just to kind of a little bit about me, I actually was doing speech pathology in undergrad. And then my senior year, while taking our last exams, I decided that I didn't want to do that with my life and I wanted to switch over. So I basically graduated with an undergraduate degree in both communication sciences and disorders, as well as psychology. And at that point, I was kind of at a crossroads of whether I would take a year off and take the MCAT and go to school here versus just going to the Caribbean and continuing forward with medical school, which is what I decided I wanted to do. And I opted to do the Caribbean because I didn't want to take any time off. So that's kind of how that worked out for me. Going to the Caribbean kind of helped because I didn't have to kind of go back and take any classes. My speech pathology classes ended up counting towards science credits that they required. So it was fine. And I was able to go directly within the couple months after summer break. So I went to St. James School of Medicine, which is on Anguilla. So in the Caribbean, you do 16 months on the island, and then you come back and you do rotations in the States. So I did most of my rotations in Michigan and Chicago. A lot of them I had to set up myself just because the options that you get through the schools, regardless of which Caribbean school it is, it's not extensive. And if there's something specific that you want to go into, you may have be at that point where you have to kind of go out there and find that rotation for yourself. Well, while I was in school, I actually was doing an online program for a master's degree. So when I was on the island, I completed a master's in healthcare administration. And then when I came back and I was doing rotations, I completed a master's degree for healthcare education and promotion. So I've got two master's degree, and they were both done before I applied for residency as well, which I think was tremendously beneficial on my application. And then obviously residency I'm doing in ENT, which I'll kind of talk about in a second. So just to kind of touch base back again with the Caribbean versus American medical school pathways. There's multiple medical school pathways. So you can be an American medical graduate. And now there's, obviously the MD and DO programs that you guys have to choose from, when they all go through the match system now. So all of the residencies are ACGME verified or certified, sorry. So it doesn't really matter whether you're going to a DO school or an MD school, because your residency training will be the same at this point. You can be a Caribbean medical graduate, which would be like kind of one step under in terms of when you're being considered for residency. And you could be a completely international medical graduate, which means that you've gone to somewhere else, and that would be anywhere in Europe, anywhere or anywhere else around the world, in South Asia, wherever you kind of go. I don't think that there's necessarily, a preference that I would give you guys. I think you guys should do what ends up being most sensible for you. So for me, going to the Caribbean at that point was the most sensible choice, because I didn't have to take that year off, take those other pre-med classes, and then take my MCAT. So bypassing that time kind of allowed me to go ahead and kick forward, rather than, just be kind of at a standstill since I made a decision to go to medical school so late. So a little bit more about ENT. So it's pronounced otolaryngology or otorhinolaryngology. So oto means ears, laryngology means the throat, or otorhinolaryngology. So the rhino means nose, so ENT, whichever way. It's something that we typically like to be called ENT especially when you're in residency. And the reason being is because if you say ORL, so otorhinolaryngology, comes very close to OMFS, which is, the things that we do sometimes overlap, but when you're on call, you really don't want to be woken up for an OMFS patient. So we prefer that in the hospital would be called ENT. ENT, the practice of ENT after you're done with residency involves pretty much everything within the head and neck aspect. So everything from skull base to, the sternum and above is within your realm. We do actually do a lot of almost like neurosurgery type procedures as well. We do lateral temporal bone resections. You can do, acoustic schwannomas yourself. You don't really necessarily need to have a neurosurgeon with you. You can do pituitaries by yourself. So it's a pretty diverse a diverse career, I guess you could call it. There's a whole bunch of things you can do. So it's a 5-year residency program. When you graduate, technically you can go out there and do all of the things under the scope of an ENT. However, there are fellowships that you can also do to kind of get some more training in them. And I've, personally, I think that like, while you may be comfortable, I think we do so much head and neck that I would be comfortable going out after residency and just doing a thyroid by myself without doing a head and neck, fellowship. But there are certain cases, like, I don't know if I would really be comfortable doing a large flap. So the fellowships would be in head and neck. So within head and neck, there's ablative, which means the surgeons who go into specializing to resect cancers and tumors. And then there's microvascular reconstruction. So those are the surgeons who come in and then reconstruct. A lot of surgeons just do their own reconstructions or their own resections. So, but those are two separate pathways that you can take to do a head and neck fellowship. Rhinology, so everything in the nose. You can do skull base with rhinology, so it's everything in the skull base, and those involve a lot of procedures like chordomas or pituitaries that you would work alongside neurosurgery, or you would go out trained to do those yourself. You can do otology, so it's ears. In otology, you can also do skull base. So at that point, you'd be doing acoustics, you'd be doing lateral temporal bone resections. You can do pediatrics. So that's pretty much everything within the realm of pediatrics. So all pediatric tumors, all, obviously emergent airways, pediatric ears. So pretty much everything. And then obviously your tubes and tonsils, which are common. Facial plastics. So I think a lot of people don't realize that ENT has a fellowship in facial plastics, where you go into that fellowship and all you get to train to do is facial plastics of the face, plastics of the face. So if you ever talk to a plastic surgeon, they might actually tell you, if you actually get them to tell you the truth, that if you want to get a nose job, you should not go to a plastic surgeon. You should go to an ENT facial plastic surgeon. There's a big difference. We are subspecialized in that spot. So our facial plastics guys are doing maybe about 10 to 15 nose jobs a week, whereas the plastics guys are doing 10 to 15 boob jobs a week. So it's very different in that aspect. So, and then you can do laryngology. So that's, the throat, laryngeal cancers, or just lots of cool procedures just about the vocal cords. That actually involves a lot of cool gadgets. So laryngology uses a lot of lasers and a lot of robotics. So it's a pretty cool fellowship to go into. And then you can do craniofacial. So that kind of goes back into the ped realm, where you can do like cleft palates and things of that nature. I always like to touch base on women in otolaryngology. I think overall, when it comes to a surgical field, women are the minority. That is beginning to change. So as you can kind of see, there's a chart at the bottom, and you can kind of see the percentage of women and the age groups of women in each thing. So in residence, you see that we are almost coming near to like 40%, and that's within that 25 to 39-year-old age group, because a lot of women are going straight from medical school into residency at this point, and without taking any time off, or taking any time off between between undergrad and medical school. So you're seeing that rise up there. We are still obviously lacking when it comes to, for sure, departmental leaders, but that's also because I think there's recently been a lot more advancement of women within the field itself. We most recently started a sub-organization within the Academy of Otolaryngology and Head and Neck Surgery. We have a sub organization now called Women in Otolaryngology. So we do a lot of things to kind of promote having, women empowerment within the field itself. The pictures on this slide are kind of the women, or are the women that I work with. There's a couple more that need to be added on now. So you can kind of look on the top left one. In the middle is Dr. Cannon. She's one of my mentors. She is now out at Duke, and she was one of the faculty members here when I started. And then with me and her are a couple of my co-residents. The picture in the middle is me and my co-resident. So in our class, there was only 2 residents, and both of us are females. And then all the way to your far right is my program chair, and the first time that he was rounding with an all-female team over the weekend. So I think, everyone within the field themselves are very excited about this change and then very accepting of it. I don't think that, I've been in a lot of panels at this point where it's obviously there's a problem in the healthcare field, especially with, women being recognized as doctors by patients or by anybody. But I think that I've never felt out of place within my own field by my peers. So I think that says a lot. And I do think that being a surgical field, it's definitely important to consider. So a day in the life of an ENT resident, I kind of broke it out into 2 things. It's very dependent actually about which service you're on. So like you guys rotate through different, different fields within the medical field, we kind of rotate within the different fields of ENT. So, right now I'm on the VA, which does pretty much everything, but the other rotations would be consistent of like peds, and we do the adult service, which is mainly head and neck. We do rhinology. We do otology, and then we also do facial plastics. So you kind of rotate through and you get the experience of all of the cases. So it's dependent on which rotation you're on, because a lot of the rotations are, obviously the rotations are different. The head and neck service is a lot more heavier. The cases are longer, whereas the pediatric service is a lot more lighter because the cases are less, and kids don't usually tend to stay in the hospital for that like a prolonged period of time, whereas at the adult service, that's not the case. So typically how my mornings begin if I'm in clinic is I have my morning routine, whatever that may be for you. You arrive at the hospital, you prepare the list. I am a junior resident at this point, still going on to my chief years, which is going to be 4th and 5th year. But you arrive at the hospital as a junior resident, it's your responsibility to make the list. So you have to have the list ready. You have to, just like in medical school, you have to have all of the vitals, you have to have all the labs, you need to know the patient in and out. Then you go round. We don't really round with our attendings in the morning. Our attendings kind of round throughout the day by themselves, but we round as a team and we get the notes done. So after rounds, then you go to clinic, and then so our clinics run all day, and you're seeing patients. The attending is always present, except in resident clinic, which is our pro bono clinic that we have set up by Dr. Medina, who's like a legend in head and neck surgery. He is now retired, but he sticks around to run our pro bono clinic. But normally you have an attending, so you'll go see the patient, the attending will, you come out, you talk, you present the patient to the attending, and they'll always come in and see them afterwards, because at the end of the day, that is their patient. You are a resident, just like when you're in medical school, you are a medical student. That's not your patient. You should take ownership, of course, but at the end of the day, that patient is there to see that attending. In between clinic, we'll have like lunch, an hour for lunch, and a lot of times you're running around seeing consults for that hour of lunch, and you don't really get full time to eat, or the full hour off, but you definitely get time to eat. Otherwise you can eat while you're in clinic. Go back to clinic after lunch is over. And then after clinic is over, then you round, and then you're done for the day after checkout. We check out over the phone, so it's not as formal of a checkout as medicine checkouts may have been that you guys may have seen throughout your rotations, if you're at that level. So a typical day when I'm in the OR, so our ORs are very, very busy, regardless of which service you're on. So you have your morning routine, you get to work, you arrive at the hospital, you prepare the list. So same thing, you do that every morning. you round, and then right after rounds, you have to get to pre-op. So if your case is starting at 7, you have to be at pre-op at 6:30, which means you are making the list and rounding way before then. Then, so you pre-op your first round of patients, then everyone goes to the OR, and then after you're done with your case, and you got to go back to pre-op and pre-op the next round of patients, whoever's ready to go. And in between all of that, you see consults, and it kind of keeps going. You operate, pre-op, consults, operate, pre-op, consults, and you're putting in orders. You're making sure that the floor patients are checked up on. It's a pretty busy day when you're in the OR, but it's fine. It's actually really fun to be in the operating room, which is kind of morbid to say, I guess, but you guys will see it's a different experience. And I definitely think that if you're a surgeon, that's what you love to do, is be in the OR, and it all comes together, even though those days are really busy. And then obviously after you're done in the OR, regardless of what time that is, so if your case is running super late or you're in a 20-hour flap, you're going to go round after that flap is done. I think that for my program, we're really blessed because I think we're all very close. So if we know that a case is running super, super late, other people from other teams will come help round. So that way the floor stuff is taken care of, discharges are done, and everything's done for those team members that are coming out super late out of that operating room. And then I just put together a couple of cases for you guys. So this is the first case. I think I only have 2 cases, and then we can go on to some questions. So 30-year-old female who complains of bilateral hearing loss, more on the right, following the delivery of her first child. The hearing loss is marked in quiet environments, but improved in noisy environments, as in not noticed as much in noisy environments. On exam, you see a normal appearance, however, with a reddish hue on the right. And then the tuning fork was negative, which means that it was normal. So I don't know if anyone can answer as to what that may be. It's totally fine. I wouldn't expect you guys to know. So it's otosclerosis, and otosclerosis is an autosomal dominant disease. It pretty much just means that 3 little ear bones in your middle ears kind of sclerose together and don't move as much with noise. And it's predominantly picked up in the middle-aged population, and in pregnant women, you can kind of see it. And the cue for that is going to be the reddish hue on the tympanic membrane that you're going to see, and then this kind of notch that you see on the audiogram. Case number 2. So this is a child who came in 3 days after beginning oral amoxicillin therapy for an acute otitis media, which means an acute infection of the middle ear space with some fluid. The patient continues to have fevers, ear pain, and then swelling and redness behind the ear. So if you kind of look at that picture, his ear is proptotic, which means the pinna is kind of pulled forward. There's swelling in that mastoid area. Otherwise, he's doing well. So the diagnosis of this would be mastoiditis, which means an infection builds up in the mastoid air cell. So that's the bone sitting behind your ear. The bone of your skull sitting behind your ear is a part of your temporal bone. And the treatment is to go ahead and do a mastoidectomy to relieve all of that fluid. And so we make a post-auricular incision, you open up the soft tissue, and then you actually drill under a microscope and open up all those air cells, making sure that you don't hit the facial nerve or any of the inner ear structures. Your lateral semicircular canal is going to be one of the first structures to show up, and then your middle ear bones, your incus, you'll notice that as well. So that's the treatment. And then you'll go in from the ear, the actual ear canal, and place a little tube. So that was kind of like a quick overview of ENT and a couple cases. What questions do you all have?
Alrighty. So if you guys have questions, feel free to put it in chat, and I can read them loud too, Doctor. Let's see. While we wait for the questions, so you did mention you went to Caribbean Medical School, and how was that process for you, just in choosing to go into Caribbean Medical School compared to just staying in United States and completing your education?
I do think that it's very dependent per person. I think that, Caribbean medical schools, honestly, they are in business to kind of accept more students and then weed them out by making exams extremely difficult come third and fourth semester, because they also don't want their step ones pass ratios to decrease. So I think that if you are motivated enough to go to an island and not party all the time, you'll be fine. But if you're going to be swayed easily by that scene, then I don't think that is the right place for you. If you need more of a stable environment, you should definitely try to stay within like a proper schooling system, such as something in the US. Okay, I think we got some questions. Don't know how to see. What extracurriculars did I do in high school? Honestly, I can't remember, but I mean, I've always been involved in multiple extracurricular activities. I know I was part of like Key Club and like all of those random little things. And, just, I mean, from the beginning, I think I I always have tutored. I started a sorority on campus in undergrad that I was president of for the remainder of the time. So, I mean, I've always, and I guess if the question is asking more so like, um, what do, like, no one's going to ask you in your residency interviews, what did you do in high school? But the point is, as long as you can show that you are a well-rounded person, then you become an attractive candidate. Whereas if you are just constantly in the books, then I don't think that most places are looking for someone like that either. You need someone who's going to fit into your group, I guess, because residency is like a family, and you don't want someone who's just there to study and work either. And you want a well-rounded person that can deal with the daily issues and can still have a life. So what issues do I face with an ENT? I'm not sure really what you mean by that. Do you want to explain a little bit more, Sam? In the meanwhile, I'll move on to Caleb's question. Do I think being a Caribbean medical grad made it harder for me or any of my peers to match? Yes, of course. Caribbean medical, like I said, you're the next hire. You're not an American medical graduate. So it's very different, especially when going for a competitive residency for, like you have to somehow make yourself like out there compared to, you have to have good step scores. So obviously that's even a legitimate thing for American medical students going into a competitive residency. You have to have good step scores. But yeah, I mean, matching into a competitive residency is usually not something that most people encourage. I mean, I was discouraged by pretty much everyone to not apply to ENT because of it. But I went out, I found my own rotations, I made sure I got my applications, I was persistent about it, and that's pretty much all I wanted to do. So I think it definitely made it harder, but it's not impossible. So I think that is something that's obvious. It's not impossible. I've met so many other IMGs that are in very, very competitive schools. I mean, competitive residencies. So definitely not impossible. What other career options was I thinking before? So I wanted to do speech pathology. My baby brother actually has bilateral cochlear implants. So I wanted to do something surrounding that. And I'm 13 years older than him. So from what I remembered was mainly going with him to his speech appointments and his audiology appointments. So I was more exposed to that aspect, which is why I decided I wanted to do that. But I don't think I was exposed enough as the clinical provider side, which I got exposed to more as I took the classes and I, was in the clinics. And then I decided this is not something I enjoy. So when I switched to medicine, all I wanted to do was ENT. Okay, so Sam said, what issues do physicians face within my specialty? So insurance companies, I mean, not really. I don't know. We don't, as a resident, you don't really deal with that kind of stuff. So I'm not really sure. And honestly, when you are in residency, I mean, every residency program is usually a community, like a state funded hospital. So you'll be doing a lot of pro bono work. So I don't think insurance, I mean, whether a patient has insurance or not, it doesn't really matter. You're going to treat them anyways. Patients not knowing what my specialty is. Yeah, excuse me, that is definitely a thing in that manner. A lot of times patients don't understand all of the things that we do, or like when they'll come to us with a head and neck cancer, they'll be like, oh, well, I want to talk to the cancer doctors. And we're like, we are your cancer doctors. But it's okay. I don't think that that's anything bothersome. Difficult patients, I think that all of you should have a very realistic expectation that the whole, Grey's Anatomy and Scrubs type patient that is always so ever thankful, that's not a real thing. I think that you need to have your own reason as to why you want to go into medicine. If you're looking for patients to give you that reason, that's not going to happen. You have to remember that while you're doing this to take care of other people, you got to have something of your own that's going to make you stick to it, because you're going to have difficult patients and it's going to put you down, and you're going to still work hard for them and you're still going to take care of them. But if you go in with that sole motivation that you want to go in there because the patients are going to give you that reason, that's not true. Like, that's going to put you down and you're not going to be happy. Jasmine says, how did I pick St. James over other medical schools in the Caribbean? How did I manage to do my master's? So St. James, I just did my research, I guess, kind of. A couple of my other friends were applying to medical schools in the Caribbean as well. So I called out and I asked which schools would take my speech pathology classes in undergrad and count them towards the science credits that were required. And St. James was one of the first ones to kind of get back to me. So I kind of just ended up sticking with that. They were pretty receptive throughout my time in terms of, like kind of supporting me in getting my own rotations and kind of helping me set that up in the background. So I don't think that I made a poor choice. How did I manage to do my master's? So there's a whole bunch of online programs that online universities such as Walden or Phoenix University that you can kind of go through. I personally am very, very interested in the fact that a whole bunch of random people in suits make up all of the rules that surround medicine, and physicians do not. And they're just kind of told what to do in terms of insurance or in terms of what, all of the paperwork and documentation or coding and all of everything pretty much. And I've always been interested in why that is, why in medical school they don't teach us anything about how to manage a clinic. They don't teach you anything about how to run a hospital. And that's always bothered me. So I wanted to do this to kind of complete my education, but it definitely benefited me in the long run as well, because I think it was a great talking point for interviews.
Perfect. While we wait for more questions, I wanted to ask you, like, how did you manage to reduce imposter syndrome, or just that feeling when you're just going towards this whole process of medical school?
Um, I don't think I dealt with that really. I think that, um, you know, like I said, you have to just have your reason to go into medical school. I think that for people that are going into it with that I'm going to save the world concept, that's wrong. I don't think that that's going to hold up long. If they're going in for money, or that's wrong. I don't think that physicians make that much money anymore. You can definitely save a lot of time and life and make more money in other professions. If you're going in for the respect, you're not going to get that all the time either. So you can't be going in for external factors. You can't be going in for external factors that will boost your ego. Um, I think that if you are real about that, then you will be able to get past that little imposter syndrome. Because I think the whole thing about that imposter syndrome is, the expected concept that physicians have a God complex, and that's not true. At least not for most people. Obviously, there are some people in every field like that, but I think that if if you don't have that, you shouldn't have an imposter syndrome.
Mm, I feel like a lot of people in United States have this kind of like misconception about going into like Caribbean medical school.
Mhm.
How do you dispel, or how have you seen in your experience from going into one and just dispelling those myths?
So like I said, I think Caribbean schools are not going to sit there and baby you and spoon feed you and tell you how to apply and all of those things. They're not going to do that. They're not really there for that. They're there to make their own money. So if you are going to a Caribbean school, which I think is fine, but you have to know that, especially that if you want to go into a competitive specialty, or even if you don't, you're going to have to put your own work in. You're going to have to find your own rotations. You're going to have to make your own sources. When you're rotating back in the States, you're going to have to put your best foot out there. You're going to have to be more bright than those American medical students that you're with. And you're going to have to get your name out there, because otherwise there's no one else doing that for you. Whereas American medical schools have that. They have that whole mentorship system. They have people out there kind of fighting and vouching for them. They have a home base where they likely will get accepted for residency. You don't have that. So I think it's totally fine as long as you're motivated enough to go out and get all those things for yourself. Caleb asked, after residency, can ENT physicians enjoy life outside of medicine? Yes, I think I already do. If you guys gonna follow me on social media, I'm like constantly traveling and doing everything else and anything else. I think the best part about ENT is, regardless of whether you do a fellowship or you don't, you go into general. Honestly, I think we are one of the most chillest surgical specialties overall, as long as you're not doing head and neck. I probably plan on working out of a surgery center and not out of a hospital, and probably working 4 days a week the rest of my life, taking 0 calls. So yeah, definitely, we can definitely enjoy life outside of medicine. Any other questions, y'all?
Let's see. So when you're going through the medical school, like what are some of the hobbies that you do to release stress and just to balance your mental and physical health?
So medical school, I don't think I has anything specific. I think I just had a whole bunch of great people around me, so it was fine. But in residency, where I'm kind of in a new, I mean, obviously I've made great friends here, but still kind of in a new place. So I think in residency, it was really important for me to find something. So I do, whatever works for you. I like to do yoga, so I do a lot of yoga. I travel home as much as possible. I think that, you need to find what it is that you need to kind of create your mental sanity, and just ask for it. I don't think anyone's going to stop you. Like I needed, before I started, our vacations were kind of broken up into 1 week vacations at a time. So you would take 1 week off 3 times a year, and that would be it. But for me, I'm from Michigan. I'm not from Oklahoma. So taking 1 week off 3 times a year I just didn't feel like that was enough. I don't know, enough chance for me to go home more often. So I just requested from my program director if I could split up my vacation days. And he said yes. He didn't even hesitate. So I just feel like, if there's something that you need for your mental sanity, ask for it. What's the worst you're going to get? A no? Any other questions, you guys?
If you guys have any questions, feel free to put them in chat. If not, just respecting everyone's time, we will end the session. Let's see.
If I could pick the same specialty, would I do it again? Yes, I would. ENT is, like I said, when I decided to do medicine, it's what I wanted to do. I wanted to do something surrounding my brother. So yes, for me, doing cochlear implants is definitely a big part of why I wanted to do ENT, but I just completely continue to fall in love with it more and more each day. I still do. Were board exams difficult? If you're referring to steps, yes, steps are like 8 hours long, not 4 hours. They are difficult, but it's fine. If everybody else can do it, so can you. That's the way you got to look at it. It's not impossible at all. You have been taught the skills on how to take standardized exams since you were pretty much in school. That's, it's not impossible. It's not there to test your knowledge on the entire human body. That's not possible. I mean, no one knows everything about the human body, right? That's why we're always coming up with new inventions or new theories or whatever. The whole purpose of these steps is to make sure that you can kind of just put together information there. It's basically like keywords that you need to be able to pick up and then that's how you answer the questions. It's going to be a long vignette with one keyword, and that's going to give you the answer. So you just have to figure out your way to study and your way to be able to process those questions.
Awesome. So if you guys don't have any more questions, I think I would like to end today's session. I would like to begin by thanking Dr. Hasina for just taking her time and coming to speak with us and just informing and giving like so much information about this amazing field. And just to like, I guess, inspire everyone to think about their medical
Yes.
specialty and just to like explore so much about medicine that has to offer. Again, like don't forget to take we don't have an assessment, so just click the Google form and you'll be getting the hours for your session for this session. Tomorrow we'll be having another session at 1 p.m. Pacific time with Dr. Epil Caldron, who will be talking more on the field of family medicine. We would like to thank everyone for coming out and just learning. Thank you.
It was nice meeting you all. Take care and feel free to reach out to me if you have any questions, okay?